I'm occupational physiotherapist Janni Säkkinen. I've been this kind of visiting lecturer from 2017 in this university faculty. The sauna, Juha and Maria-Liisa Laitala and all those persons asked me, can I have this kind of ergonomic presentations for the dentistry students? And this is the reason why I'm here. If you have any questions concerning about the topic, hit me and I will try to answer best I can. And we have a few slides to go through, and this is the first time in English, so don't know how does it goes, but if I say something wrong or bad, or if it's really hard to understand, then tell me and I will go to find the better words for it. So where does the word ergonomics come from? They come from the Greek, and ergo meaning for work and nomos meaning for laws. And if we think about the work in total, we need to do it as efficiently as we can, and we need to do also other things that we can be in good shape in the long run, that we can go through the whole work years. And what does these two pictures have in common? Well, does these have in common? Shit happens. So in everyday activities, you will going to end up in a situation when you are not able to do the stuff so ergonomically. And when, for example, you go for the gym, you need to push for the higher peaks to get your muscle endurance and total strength way more better. But that is the biggest thing. We cannot get rid of those bad ergonomic postures in the long run. But what we can focus on, that you can get used to everything. So once you start with your profession, you start to work with the clients, there will be shaky hands because you need to be really focusing on the task what you are doing. But for example, when you go 3 years forward, the shakiness of the hands goes away because you know that stuff. So that is the work experience what is affecting on the background. Also, you start maintaining and getting new techniques how to do the different stuff, because once you graduate from the school, you got this driving license that you are able to do the basic stuff, but after that you will going to start getting experience how to do it eventually and better in the long run. Also, you are starting the profession where there is plenty of people trying to get to similar school in Finland. You don't need to pay for school in Finland if you go for the university studies. And people really want to go to different kind of places, but amount of the people what they can take in is limited, so they can really choose the best from the best. And that means that if you want to go for the school, you need to be really focused on that topic or that profession, and it tells that there is a self-efficacy on the background. You are willing to do the work to get you through the tests. And also, if we think about everything in life, when we do stuff in a bad posture or something like that, we need to have also good recovery. So if the night sleeps are going bad, if the work-life balance is out of the window, then you will going to end up in having some sort of issues. So try to focus on that you will going to recover from everyday tasks. When I checked the articles from the background, what kind of stuff does make the people in dentistry go for the early retirement? There was this Gupta article from 2014. In that article, there was this mentioned that 60,000 hours in lifetime working in tense and distorted positions. So you will going to end up in a situation when you need to put yourself in a bad posture at top of the client to get that stuff done. And those kind of stuff happen. And you will going to be spending a lot of work in that kind of distorted postures through the whole work career. The biggest factors what causes those early retirements are musculoskeletal disorders, and that covers about 30% of the population in that study. There is also cardiovascular diseases, there is symptoms of the neural tissue, there is tumors and diseases in the neural tissue. If you think about the symptoms of the neural tissue, it has radiculopathious, it's difficult to say, encephalopathies. So, meaning we have, for example, medial nerve. The medial nerve makes the sensation to these areas, so we might have a certain nerve problem. Something is pressing against the medial nerve, and that is the situation what we have in the hand. We might also have carpal tunnel syndrome, nerve injuries and stuff like that. But if we think about the disease in the neural tissues, there is this MS disease and polyneuropathy, and those are the different kind of cases. But we need to really be focusing on the musculoskeletal stuff, because if we can get rid of those, we can reduce the risk for the early retirement. And also, if you start to have some sort of issues in neural tissue, we need to get them sorted also. More about those articles. What kind of stuff starts to happen during when we start to have pains in the areas? We start having reduced ROM, range of motion, so there will be limitation in the shoulder movement because of the pain, for example. Abnormal skin sensations. When there is something pressing against the nerve and nerve cannot have its own circulation normally, then it starts to have this tingling or burning sensations what start to come to the area where the nerve is innervating. And also when the irritation stays for longer, then the abnormal skin sensations might appear. For example, typical case in my office, client comes over to my office and tells that okay, she or he has this carpal tunnel syndrome, and the issue is that it has been present for longer periods, and now when he's walking outside and there is a minor wind going against her body or his body, then the irritated area might feel the wind way more harder. So the irritation of the nerve is way more worse in that kind of situations. Also, reduced compression force of the hand, lack of coordination. For example, if we think about the nerve roots what comes for the cervical spine, C6 innervates the biceps. And when the nerve root starts to go for the biceps, there is this motor units in the muscle fibers. If there is a good contraction and good control of the motor units, then the activation of the muscle is good. But if the innervation of the nerve going to the muscle is not activating all of those motor units, then the force, well, the peak force is reduced. So people go to the gym, they start working out every new year, and they think that okay, I'm gaining really much strength in a long periods because I can build up the weights what I'm using in different kind of machines quite rapidly. Typically, in most of the cases, first starts the motor innervation of the muscles going to better. So that is the one what is increasing the maximum output of the muscle. And when we end up in a situation when we need to build up months of work to get the weights better, then we are working only of the thickness of the muscle and maximum output of the muscle. So motor units starts working first, and after that comes the total force what the muscle can produce. Also, we might have these stiffness feelings, we might have these cramps, we might have these tingling and burning and electric shock-like pains. And there was this MES article from 2019 where the number of the participants was 234, and they asked what amount of the pain are the persons feeling. So that is measured in WAS, 0 no pain, 10 the worst pain ever. And also there was this frequency, how many participants answered the pain having similar positions. And if we think about the male, there is certain aspect about the painful areas, and here is also what female participants felt the pain and how big pain do they felt. Issue with the females is that the soft tissues are way more flexible compared to the men, and if you have really flexible joints, then you really need to focus on having the mid posture of the joint, because that is the best way to use the joint. If your fingers are extending really, then you might have some sort of issues in the long run. But we will going to get into that in a bit. So, how the path of the trouble comes? We start with the repetitive movement, we start to get the fatigue, we start to get these extreme positions. When the muscles get fatigued, they might get also imbalanced. And if we think about the muscle, ways we can use the muscle, we have this contraction, we have this static, and we have this eccentric muscle contraction. When we are doing static postures, the muscle is working. When the vessels tries to bring oxygen and nutrients for the muscle to go on with the stuff what it needs to done, then the muscle activity blocks the circulation. Then we start having this milk acid building up to the muscles, and depending on the capability of the muscle to maintain the milk acid, then we start to feel this fatigue feeling. And if you are if you are able to maintain this kind of posture for the 10 minutes, when it really gets fatigued, you need to drop your arm down, and now the circulation can go to the deltoid muscle. When you continue in similar posture, you are not able to go that amount of the time because there is also this milk acid built up also already. So when the gap fills up, then you need to stop the movement. And ischemic pain mechanisms, for example, in low back, is really frequent in my office. They come from left and right. But we will going to get into those pain mechanisms in a bit. We also get these ischemia, what I've just mentioned, and also triggers. Typical cases is that, for example, common doctor sends the client to my office and tells that, okay, she or he might have some sort of radiculopatelis coming from the neck. Irritation in here and stuff like that. Then I check the Spurling test, I do the extension, lateral flexion and the rotation. And this is the posture and position when we really shrink down the areas in the cervical spine. So if that causes the typical pain to the arm, then I know that neck is some way related to that client's issue. If I really want to force it, then I put axial pressure downwards because now I'm really doing the stress to the tissues, and if it shoots down to the arm, then I know something needs to be done with the neck. But if the Spurling is negative, then I need to check how is the reflexes, triceps, biceps, brachialis and the finger flexors. Then I need to check the myotomes, how the muscles are working coming from the cervical spine. C1, nodding of the head, C2, rotation of the head, C3, trapezius, C4, diaphragma, C5, deltoid, C6, biceps, C7, triceps, interosseous of the fingers, C8. And if there is nothing lacking, and when I do the certain test for the nerve, for example, if it's radiating somewhere in here, I do the medial nerve pull, and if it's negative also, then I really need to start palpating that client because there might be also this kind of trigger pains. And for example, if you go for the Google and you put over there trigger points, you will going to end up in a page when you, for example, well, check that. Go to Google, triggerpoints.net should be the site. And once you end up in there, find the muscles and go for the infraspinatus. Yeah, and you should find from there the muscles and find the infraspinatus. Bogduk 1984 started to inject capsaicin to facet joints, and he started to ask that where does the client feel the facet joint irritation. Then he made a map about it. Then he started to put capsaicin also to the muscles, where the clients tell where the irritations come. And if you think about the amount of the persons what answer it the same way, more the red dots, more the answers pointing to that direction. So triggers are also quite common in normal practice. And if we think about the pain in head area, we might have this radiating pain or tingling or numbness or something weird going on. And then we need to really be focusing and thinking what is the area. And if you think about these X marks, those are the places where we need to put, for example, acupuncture needles if we are using that for as a part of the treatment. But that comes also. Triggers and diseased decreased movement, nerve irritations. 2007 I went to Rovaniemi to have my school for the physiotherapy, and first time I ran to this topic, biopsychosociality. And I thought myself, I'm never going to use that in my life. That is total crap. And how wrong I was. For example, let's take a low back client as an example. She or he does their everyday activities, bends forward, he has some sort of sharp pain to the back, and it causes everyday activities to go really, really bad. If they start to fear the movement, they are not allowing themselves to go to the forward flexion because they might feel that it might broke something during the next movement. So he or she prefers to block that movement. Then if she or he goes to Google and starts searching internet about information about the low back, they go to the forums and shit happens after that. So they might do the pain catastrophizing. Then might come anxiety, then there comes the sensations, emotions, stress and personality. And when the client comes to my office and when I start to interviewing he or her, I try to find a way what kind of stuff does she or he does in free time, because if they like to do different kind of stuff, challenge themselves and stuff like that, then I know that self-efficacy would be quite good level in that cases. But if they are only doing stuff what feels comfortable for them, they are not pushing themselves. And in most of the cases, if I have that kind of client, I always need to be like a guiding them forward. And it feels stupid, but some people need someone to come and take the hand and let's go to this direction. Well, it's their pain, their story, but some persons need some sort of guidance, and with the rest of the person, you just need to point the direction and they start going to that direction. And they will going to get into there. So we need to think about the persons and what they are able to do. Simula had this great paper from 2020 from southern part of the Finland's population. What is the most predictable factors concerned about the chronic low back pain? So high BMI, smoking, passive lifestyle, low level of education. We are not able to affect on the low level of the education in each individuals, but if we have a chronic pain, for example in low back, then we need to also tackle the factors on the life-like terms or life factor stuff, because if we are not focusing on those, we have this chronic back pain and we know that we need to approach it from the multiple directions. 2020, this Finnish professor of physiotherapy made this book about the pain mechanism, and it was professional's pain book. Excellent. And I wish that I would be ran to that book way more earlier, because first time in my profession I started to notice that what I need to really focus on the interviewing of the client. It was the pain mechanism. Because when the client tells me how does the pain work, then I really know what I need to be focusing on, and then I can drop the rest off. Because the issue is, if we think about the orthopedic test for the shoulder or for the neck and stuff like that, there is a shitloads of them. If we try to do everything in 1 hour session, we are not going to end up nowhere. And from interviewing in certain way, we know what kind of pain mechanism client might have, then I need to test it. Then I need to find a solution. How can I get the typical pain mechanism from the client away? Because if I can reduce the pain what the client is feeling during the meetup, then I know what stuff I need to guide to that person to home. And that is my only task. So if there is a certain movement, for example for the low back, what causes the typical pain, I tell the client do that. Then I need to start testing how can I move that. How can I change that movement in the way that client is not feeling the typical pain, and I just send back home to do that kind of stuff. And it's really easy. And if you want to have some sort of small brief YouTube video about it. Then you can use those QR codes, and I will going to send these lectures also to Sauna-Juha, so he can send this lecture to you, so you don't need to be putting these notes up. But check those videos, because those QR codes will going to take you directly to these videos. But we will going to have minor and short brief about those pain mechanisms. If the client comes to my office and she or he tells me that, okay, I bruised it with my ankle and after that the squatting has been bad, and she or he tells me that when I have the shoulder length posture, when I go down, I feel the pain in upper ankle area. So they will go to point of the pain coming into here. I said, excellent, okay, what kind of stuff, what we need to do with that. Then I check the ankle, range of motion in there. If there is a clear restrictions in the upper ankle joint, what does the dorsiflexion and plantar flexion of the ankle. Then I mobilize it open. I ask client to do the same squat again. If the pain has reduced it, then I know, okay, what is the favorite band of yours? Okay, Queen. I will going to go for Google and, well, the YouTube, check best song for Queen, rounding 3 or 4 minutes. Then I will going to get the client's cell phone and start doing the video. Do the video about the song. You will need to have this song on the background when you do the ankle mobilization to this direction, and he will going to, or she will going to do the movement in my clinic when I film it, that she or he can do it correctly, and then I take the cell phone back to her or him. And that is the way I do it, because I'm terrible at the drawing. It's way more easier to do the video and have it in certain length that the person is doing stuff for 3 or 4 minutes. And if the music, what they like, is good, it will going to have some sort of mental effect also. You can use that also. So they are usually avoiding the painful movement, and the anamnesis is short, acute, clear, how and when it started. And in that kind of cases, I attend to do manual therapy, and it's my job to find a way to get the pain reduced during the movement. And I do different kind of stuff in different kind of clients, and once we find the right spot how to do it, then we continue with that. Well, the weather is terrible outside. When it gets freezing again and the water comes, it will be black ice everywhere. And people tend to bruise their wrists when they fall and hit their hand to the ground. And typically in those kind of cases, I check the wrist movement like this, wrist movement like this. Okay, right hand has the pain. Then I do the painful movement, and then I do radial side pressure, ulnar side pressure. And when I know that there is 8 bones in the wrist area, then I start mobilizing the certain bones to certain direction, because the pain goes away or reduces. Then I say to the client, okay, you need to be doing the mobilization to radial side of the wrist. So they will going to have this kind of posture in hand, blocking the bones what they need to be blocked, and then they will going to extend elbow upwards. Easy mobilization, and that is the way they will going to get their wrist going normally. Inflammatory pain. Clients typically tell that there is a clear area, what is red, swallow it, there might be this pulsing sensation. When the person goes to rest, then the circulation goes over there and it provokes the typical resting pain. And when they start doing the minor movements, the rest fades away a bit. If they take anti-inflammatory medicine, for example, Burana or something like that, if it reduces the symptoms 1/3 or half, then we know that, okay, there is this inflammation going and we need to get that away. Typically, the anamnesis is short, there is a clear reason, and it's acute. And with these kind of clients, we need to be really telling that, okay, it's normal, the body has the inflammation, it goes away. So we need to reduce the catastrophizing and avoiding negativity with that kind of clients. And also try to tell how to use the medication right way. Also, we have these persons what have these pains going everywhere. They might have one day with the pain in the right wrist, next it might be at the left ankle, right hip, left knee, it goes everywhere. And in that kind of factors, I usually start thinking that is there this minor inflammation going all the time in the body, and those cells just go to certain area during that the person starts to feel the pain over there. And in that kind of cases, we really need to be talking about the nutrition factors on the background because they tend to eat like shit. And if you really want to focus on the mechanism, how different kind of natural stuff what we can eat can reduce the inflammation and how they do it. Hankison sisters made excellent article in 2012, nutrition model to reduce inflammation, and it's really good because it talks about the mechanism when and how that, for example, turmeric or ginger and stuff like that work to block the inflammation in the body. It's really good to read. Ischemic pain, and this comes from left and right, for example, concerning about the back pain. When you see the person what is goes to the bigger market, they have these trolleys in front of them. They start walking in the supermarket, and when they continue, for example, if there's a better half also that you need to walk behind and go from every aisle to every aisle, they start leaning forward. And you can, if you check them and frequently see those persons, they start this weird sweat coming from the head, and you can see from their faces that it's really getting frustrating to low back because they want to lean more and more forward. Issue with the ischemic low back pain is that when the glutes are working hard, when the low back muscles are working hard, when the back extensors are working hard, there is this static contraction in the muscle all the time. So milk acid start to build up. More the milk acid there will be, the more fatigued it will be. And once those persons sit down for a bit and lean forward and try to relax their back, it will going to melt away a bit about the pain. But once they stand up and start going, the muscles tense up, and after that the shit hits the fan. So more fatigue they will going to get, the more pain they will going to have. If we think about the hip flexor, if we think about the glutes and the abdominis muscle, glutes, low back muscles, and the back extensors, in most of the cases we just need to reduce the ischemic state in those tissues. Or if it's, for example, deltoid area, we just need to get rid of the ischemic mechanism in there. And typically everything what promotes circulation is good for those. For example, warm packages, good exercises, massage and stuff like that. And if I have this ischemic pain mechanism in my office, for example, forward bend is really restricted. Then I check the glutes, then I check the low back muscles, then I check the back erector, then I do minor massage for those and do the same flexion again. Because if they are able to go further with less pain, then I just guide, okay, what is the favorite band? Let's have massage instructions for you for the whole. Typically, in those cases, the symptoms melts away to the half, or in some cases completely gone. But for example, if only the massaging takes away the issue, for example 50%, and it remains the same, then we need to have a different kind of approach. We tend to have the posture supported with the muscles what has really much force. So in those kind of cases, the glutes, low back pain, low back muscles and the back erectors are doing really much of the work. So we just need to activate the opposite muscles. And if we think of the reciprocal inhibition, when the biceps contracts, always there is a tricep relaxations. And with the low back pain clients, we need to activate the hip flexors, the abdominis muscles to get relaxing innervation to the back muscles, and we just need to focus on the belly muscles and we get the rest 50% away. And this is really, really common. There might be, in anamnesis, there might be issues present for longer times, perhaps in years, and they start affecting more and more everyday activities. And what should be done? Exercise strength, endurance, patient education, and also those facilitating factors that sports, heat and massage, because they need to just get those tissues relaxed, and after that it starts easing up. And let's go for the nerve pains in extremities. When the client comes to the office, then they tell that, okay, they have this issue present. We can think about the innervation of the nerves concerned about the level of the spine, for example, cervical, lumbar, or stuff like that. And we can also think about the dermatomic areas concerning about one single nerve, what is innervating that area. But when the client comes and says that, okay, I have this low back pain, what starts to radiating down to the glutes area, going down to the thigh and calf, I just ask, is it at the fifth toe, is it at the big toe, or where does it go? And it tells me that, okay, I need to be focusing on the low back area. There is typically radiation, tingling, numbness, burning, or piercing feelings present. If we think about the nerves, we have these myelin-sheathing nerves, and the myelin-sheathing nerves are meant to preserve life. If we think about touching the heated surfaces, or if we think about that we are touching sharp needles, then we need to have these reflectory movements when we need to pull the hand away from the heat source or needle. If we touch something, then innervation comes to the central spine, and after that it shoots back that we pull our hand away. Typically, when the nerves are contributed to the symptoms, they have these really extreme feelings, but we also might have these different kind of feelings in the dermatome area. For example, non-myotic myelin-sheathed nerves, they are giving the feedback to the brain concerned about the pressure changes and the vibrations and stuff like that. So if the client tells me that, okay, she or he has this medial nerve issue present, but the person tells me that it's like a warm water, or it's like something pouring something in that area, then I know, okay, it might be those nerves what are not myelin-sheathed, because the sensations what comes from that are different. So if we have a sharp pain, this electric kind of feeling, then we think that, okay, it's the nerve what has these myelin sheets on. When we have these mild sensations what comes and goes not that rapidly, then we need to think that are those nerves what are innervated, non-myelin sheets what are causing the issue. And also we have these pain-specific C fibers in our body. Issue with the C fibers is that, for example, if I broke my arm with those slippery weathers over there, I have the cast top of my hand. The cast is making pressure to somewhere in my body, and I don't go and fix my cast. The C-specific fiber starts making innervation from the cast pressure, and also there is tissues and nerves what makes this innervation for my brains about the cast presence. And because of those C fibers are polymodal, they might take the role of different kind of nerves. So when they get the cast away, then the normal tissues what are giving the sensation about the pressure of the cast goes away, but after that the C fibers continues giving that feedback, and then we have these really bad pains and really difficult pains, because then the body is doing the pain by itself, because those C fibers do have these polymodal capabilities, and they start doing that, and those are really tricky. So thinking about the ghost pains and stuff like that, that might be the factor on the background. With the nerves, we need to take load of the nerves, we need to get supports or taping and stuff like that. There might be accidents or surgery or injuries in the background, and sometimes symptoms may be present for longer periods. And also, as I mentioned about those triggers, if there is no clear findings when we test the nerves and stuff in concerning about the nerve mobility, then we need to think about the triggers. Descartes 2016-2017 made this nociception model, what has the idea on the background that when we got this sharp needle over here, the nerve innervates, goes to the central spine, then goes to the brain, and brain interprets what has been felt in what area. Nociplastic pain is that we have these innervations, but the body is making those innervations to go way more worse. If we think about situation when we are driving or going outside, and if we feel ourselves threatened, or if somebody else goes to threatened situation, then the adrenaline kicks in. Our heart feels that it's pumping out of the chest. We get this really informative senses that we can see everything, we can smell everything, because it's meant to be that we need to preserve the life, so we need to run or fight. And during that kind of cases, the body is really alarmed. If we think about the cortisols, it has similar effect, but the cortisol levels rise in longer periods, so it's really difficult to find out what was the feelings today compared 6 months backwards. And during those situations, if we have this nociplastic pain, then the area might vary. So client might tell that, okay, it's whole lower body or upper body or half of the body. And the pain goes up and down, and client is quite frustrated about what we need to do about that. And in those kind of cases, then we need to think about the recovery and overall how the person is preserving his life or she's life, because if there's really stressful factors in every direction, if there's a lack of sleep, then we know that the body is really focused on every sensation, because the body is really alerted concerning about the cortisol. And that kind of clients also comes to the office. But if we think that I need to check every joint in the lower extremities, I just check 1 or 2, because there is no difficulties with the range of motion or with the joint functions. Then we need to start talking more, because I'm manual therapist, so I need to check something. So I check something, but I know that there is no answer in here, so I just need to continue by talking. And that kind of stuff also comes. And I'm frustrated that persons are not, well, there is shitloads of information, but I wanted to make it a bit more easier. So if you have carpal tunnel syndrome, if you have this ulnar nerve or radial nerve issues, then there is a test, how to do the test, how to get rid of that irritation, and it's public to everybody. And if the client tells that she or he has some sort of issue, you can say, okay, go to my YouTube and there would be good information. So, as I mentioned it previously, the Bogdok in 1948 started to do those capsaicin injections to facet joints, and as we can see, the radiating area of the certain facet joints comes to certain area. So if the client tells me that, okay, she or he has this radiating, well, some sort of pain in certain areas, then I need to check, is the facets going normally in there. We have also these, let's do this kind of stuff. Get good posture when you're sitting in there. Place your index finger back of the skull. When you found the back of the skull, there, in some cases there is this bony bump, but some person have it, some doesn't. Go downwards and you will going to feel this U-shaped structure, and when you go down at the middle, you will going to end up running to cervical number 2. And then go up and go over here. Now the index finger should be quite close to our upper neck muscles. Now close your eyes and then think that you want to move your eyes in a big circle against the clock, and do the big circle in clockwise, counterclockwise and clockwise, and think, do you have any movement or muscle tension against the index finger when you think about moving the eyes, and do the lateral movement and do the movement up and down? Because when the eye starts to move, then the proprioceptics of the upper neck should start moving also, so you should feel the contraction of the muscles. Do you feel it when you move your eyes? Yeah. There should be connection. And when we think about that we are getting the certain kind of postures and, for example, eyesight, if we need to be checking above the horizontal plane of our eyes, it's really fatiguing. And when we check up, we attend to also activate the upper neck muscles. So we attend to do this kind of stuff. So usually keep the subject lower to the horizontal plane. And also the upper neck affects our jaw movement. So think about when you go to this kind of posture that you're going to be sitting in front of the chair, tilt your chin forward and go to bad posture like this and have your neck like this. And then think about the jaw movement when you open up fully. I've been told that you need to get 3 fingers in vertical plane between your teeth, and it's good range of motion. But if we end up putting our clients in a situation when the neck is retracted, well, protracted in this case, then think about the mouth movement and then go really upwards and then open up the mouth. Is there wider range of motion when you have this good posture when you open up the mouth? Because in this posture, the movement of the jaw should feel really, really tight and stiff, and in this, it would feel way more better. And when you move your jaw, your upper neck also moves. So here is a video about that. Check that area in the video. There is this tilt of movement when she opens the mouth. So if neck is really tight into this direction, it cannot go further, and if it's restricting the jaw movement, then we need to sort out the upper neck area. And I'm in luckily position because the few of the dentists here in Oulu sends me these clients who have these day and day issues, because I'm really glad to work with that kind of clients. They might have this tinkling or something sensation, or they might have this locking in the jaw joint and stuff like that. And they just tell the client that, okay, book time for me, and they will going to come over here. And they are really, really nice to work with. But I cannot only be focusing on the jaw, because I need to focus on the upper neck area also, because in most of the cases they are really related. And if you want to have one test what really easily checks the upper neck movement, then it's this. You will going to force your client's head chin to the chest, and then you will going to do rotation to both sides. If the jaw can go towards the armpit, then the upper neck movement is excellent. But I've ran into a situation when the client comes to office, she or he has this jaw issues, and when I check this, the limitation is really, really clear, and opposite side movement is really, really good. So in that kind of cases, I know that I need to be working also with the upper neck area. So craniocervical flexion test and rotation, use that if you think that there might be something contributing to the client's issue with the upper neck. And there is these articles that what kind of stuff comes together, and when you have these upper neck issues and when you have these jaw issues, they typically walk the same paths. Other contributing factors. We cannot get rid of the age, so every year we get this 1 year more, and that is how it goes. Lung elasticity goes down, so it affects on ventilation capacity. Stroke volume and the heart and the maximum heart rate goes down 1 hit per year. Peripheral vascular resistance goes heavier. Aerobic and anaerobic endurance weakens by 5 to 10% over 10 years, with in principle 1% per year if there is no load. If we think about the muscle cells, the fast cells goes out of the window first. So if we think about the muscle, we need to do fast movements also when we do the resistance training. We need to also get those muscles recruited, and stiffness and the of the agonist and antagonist also starts building up when we go older, and that is how it goes. But big picture in this, use it or lose it. So use your aerobic capabilities and do something what requires strength, and you will be good in the long run. If we think about the work and the maximum what it can be concerning about the work, for example, if the lateral rise of my shoulder is 10 kilos, then the maximum weight what I'm able to do in lateral rise would be 10% from the 10 kilos, so 1 kilo. And in that kind of cases, the amount of the muscle activation needed in the work is low enough so it won't cause any issues. If we think about the aerobic stuff, then it should be half of the total capacity. And typically when I have this client what works in industry or they build stuff and well, the stuff what is considered to be heavy, they always tell me that I don't need to train on my free time because the work is so heavy. And I really fed up to that point. And I started to search an article giving backup for my advice. In the Danish population, there was this study concerned about the heavy workers, and does the heavy work prevent from cardiovascular diseases? And the number in that study was 233,000, so shitloads of persons. And the most thing what affects on the cardiovascular diseases are the activities what you do at your free time. So shit happens. And in heavy stuff, the issue is that when they are not taking care of themselves, they end up having this normal decline of the aerobic and muscular strength. But if the work needs to have some sort of level, then at some point we end up in having situation. And same comes for the policemen, same comes for firefighters, because if you get fatigued, you start getting errors in your job, and if the laziest or if the worst person in the whole group is the last when you need to go for the fire building, you are not feeling yourself safe. So they need to have certain level of capabilities what they can do. You don't want to be the worst of the bunch in those kind of cases. And does the exercise make our muscle mass go better? I'm not telling that you need to all start doing these triathlete sports, swimming and biking and running. No way. But if you do some sort of stuff what maintains your good muscular health, then it's going to be preserved in the long run. There is a 70-year-old triathlete and there is a 74-year-old sedentary man. And if I would be needing to choose from one of these, I would go 10 out of 10 with this, because those muscles can do these fast movements. So when the person starts falling, he or she can do the movement. But with those, there is not that much of the fast muscle cells. Let's start with the chair selection. These are terrible stuff, seriously. They just made the chair what fits most of the people, but if you are shorter or longer, these chairs are terrible. When you go for the your place where you start to doing your work, you need to think about adjusting the chair similar way as you go for the new car. You always adjust the stuff suitable for you, because no one else is going to do that. If we think about the height of the chair, if we are using these kind of chairs, we need to get our kneecaps safe. So the height of the chair comes from the height of the tibia and fibula. When there is a 90-degree angle at the kneecap, then there is nothing blocking the circulation, and then the seating posture would be quite good. If we think about the support underneath the thighs, we need to get the support area wide as possible. So there is usually this kind of seat depth adjustment also for that kind of situation. And there is also this angle, because if the angle is pointing from back to upwards, then you will going to start feeling the pressure underneath the kneecaps, and it's not good. So 90-degree kneecap, always pressure from the thighs, and get the support area way more bigger. If we think about the posture in the work, if we do the regular stuff when we have our elbows close to the body, then it's quite efficient for the body, and when we do the regular stuff in here, it should be quite fine. If we need to apply force to it, then we need to drop the elbow downwards, because now we can activate the big muscle in the back area. So if you need to do something what requires force, stand up and do it underneath the elbow line, because now you are able to use way more force. And if you need to do really detailed work, you need to have the good visuals, then have elbows supported at somewhere. So now your shoulders can relax. They are not doing the static posture. And for example, if you are doing adjustments for the night pressures and stuff like that, it's really good to do in here, because you can do it precisely. You don't need to shrunk your shoulders to maintain the posture, because this would be terrible. So in precise work, always try to find a way to support your elbows. It's way more easier that way. Think about the active and passive sitting, because when we are sitting in this kind of posture, this is considered to be passive sitting, so I don't need to be using my muscle to maintain the posture. When we go for the saddle chair, that is meant to be active sitting, so in that kind of cases you are using your belly muscles to maintain the good erected posture. But in those kind of cases, you want to have the seat feeling comfortable against your glutes, because if there is these sitting bones in the gluteal area, if they are pressed way too hard against the saddle chair seating part, then you will going to start get this compression and you will start to get this discomfort. So try to get the saddle chair this adjustment that it's comfortable against your pelvis, because there is different kind of pelvis in every person. And also if there is a wider and narrower seating position in the saddle chair, adjust it also, because there is chairs where there is this saddle chair adjustment, also there is this kind of adjustment. If there is a backrest in the saddle chair, it's meant to use that when you are sitting down, the backrest is not there, but when you slightly slump your low back, then the backrest should be in there. So if you need to maintain that posture for the longer periods, then you are able to use the backrest, and typically you are not using the backrest. And that is active seating. In both, I have videos how to adjust the saddle chair, how to adjust the normal office chair. And also work while standing. So when you run up in the company where you start to be working, try to find the ways what kind of task are you able to do in different kind of postures. For example, normal checkups. Are you able to do those normal checkups, for example, in standing position? When you need to do the heavier work, go underneath the elbow. When you need to do precise stuff, and try to find the ways that the postures change during the workday, so you are not sitting 8 hours in passive sitting, because that is the worst. Pay attention to the colleagues. It happens if you are 2 meters long and you have this partner what is 150, so there is ergonomic issues present. So try to cope with that also. Remember that those colleagues will be by your side years to come. Approach angle and the customer guidance. If there is a young person but there is no neck issues, if it's easier to see the visuals in the mouth, then rotate their head, then extend their head. But remember, if you protrude the neck, then you might having jaw limitations concerned about the neck placement. And placement of the work tools. Try to find different ways to put them so you will going to get minor movement in everyday activities. Pedals. That is the typical pedal what we have in Finland. And if we think about the hip external rotation and internal rotation, you will going to use the RPM or the function of that pedal via that. If you need to do this kind of tags what require certain kind of RPMs, you just place the pedal over there and push it forward. So the weight underneath the heel bone will going to make the pedal go to certain RPMs. So if you need to go for the longer periods in certain RPMs, there is no point statically do the external rotation, because if you roll the pedal like this when put your leg forward, then it's way more easier to do the similar RPM for the longer periods. Try it. If it feels like shit, then continue, but if it's worth trying or worth applying, then go for it. If we think about the muscle contraction, and we have this supraspinatus muscle, it has been measured that after 30 or 45 degrees, the supraspinatus muscle is really contracted, and the issue is that acromion, the bony prominent in lateral part of the shoulders, the supraspinatus comes underneath it. So if we end up in a situation when we need to do a lot of work in this kind of postures, then the deltoid muscle comes to also to assist. If we need to do a lot of work in these kind of postures, then we need to think about the height, how we are positioning ourselves concerning about the client. If we can drop the elbows down by lowering the client, always lower it, but sometimes you will going to end up in a situation when you need to really be at the top of the client to get clear visuals and do the work, but that happens. If you start to have shoulder issues concerning about that, get massage or lacrosse or fascia ball, place it over here and start massaging, because if it eases the pain during the abduction movement, then you are going good. Then about the inhalation, let's get this kind of posture. So you are doing precise work, top of the client. So sit at the front of the chair, then bend forward and be like this. Try it. Get this posture. And do the inhaling from your nose and exhale through your mouth. And think about how much lung capacity are you able to use in that kind of posture. And then get yourself upright and then do the inhaling and exhaling again, and think about the maximum amount of the air what you can get inside of your body in that kind of posture. Were there any difference? As mentioned previously, diaphragm comes from C4, that the C4 innervates the muscle. When we are leaning forward, the diaphragm muscle is big muscle underneath our chest, and when it activates, it pushes itself downwards so we can get the lower parts of the chest to be filled up. During the inhaling, this muscle goes downwards so we can get the lungs filled up. And when we put, for example, those lungs in here, ding, those are the areas what we need to fill up. But in case if we are bended forward, we are not able to use the diaphragm. So in that kind of cases, we are using the lungs capacity from the up and from the middle portion. And if we think about the change of the carbon dioxide to oxygen, then the exchange is not that efficient. So only way how we can get the certain amount of the circulation and certain amount of the oxygen going to our system, then we need to elevate the heart rate, then we need to elevate the frequency of in and exhaling, and then the body goes to a bit more alerted state. So if you find yourself doing this kind of posture all the time, and if you feel dizzy or something like that, just try to get the posture way more better, because during that posture you are able to use the lung capacity way more better. It's sad because this software was in Microsoft Store for $15, and I bought new laptop. I tried to get to Microsoft Store and buy this and log into my account so I can download it again, and it was not available. So as long as I have this laptop, I am able to use it, but if I want to get new version of the Essential Anatomy, then I need to pay these monthly fees, and it's stupid. But if you want to prevent it, here is this Zygote body. So for example, wait a bit. in here you can place the markers like this. You can get the skin away and you can get the certain muscles away, and it's way more easier to show the clients what you are doing. For example, if I show stuff from here. But the issue in this is that when I get the digestion, circulation, lymph and nerves away, I end up only having the cartilage and the muscles. When I go over here and I point this one, this is the only way where I can do this kind of movement. But when I'm at the normal vision, when I do this movement, it only rotates in this way. And this is Frebare. So bookmark this to your laptop what you need to use at work, if you don't have any. And when I do my videos to YouTube, I would love to have some sort of presentation, because only way where I can do it safely is to use the Wikipedia's common law pictures and stuff like that, and you have seen them everywhere. And I used to play with the Legos a lot, so I prefer to have 3D dimensional sight about the issue or stuff what I'm talking about, so this would be good. But I sent 2 or 3 emails to that company. Can I use your software as a presentation in my YouTube videos? And they didn't reply. So I went to here, and again, LaTeX, not good with that. So I copy-pasted it to ChatGPT and asked it, am I able to use this stuff in internet? And it told me, no, you need to be subscribed user of that program to show it in internet. And it was expensive also. So it's good for my client work, but it's not good for the videos. If you find any, please let me know. Yeah. So inhalation. And as we can see, here is the neck posture and the spinal stress. So when we lean forward with our neck, the head of the weight of the head is 8% about from the body weight. So when the level goes further, then the resistance what required to do from the muscles is way more bigger. But if we think about the neck posture, does it correlate with the neck pain? No, it doesn't. In the big picture, what correlates with the neck pain is a physical passivity. So if some teenagers, or if you find yourself checking your cell phone in this kind of posture, no worries, it's not causing you pain, as long you will be active in your free time. Elements related to Viseo. So when the distance to destination is bad, or if it's not lighted properly, then we are attending to do this kind of movement. So when you do precise work, light it up, because you need to have good, clear visions. Think about also the spotlight and shade, because the color of the light might also feel a bit awkward. These lights in here should be around in 5000 Kelvin, but if the Kelvin is lower that, then the light appears to be a bit more yellowish or different color. So aim to focus to have the neutral light, and always when you are using those stuff what you put loops, yeah, then the magnification will going to make it easier, but always think that you need to light the mouth properly, and then when you start doing your profession in normal way, try to find the loops what is good for you, because it will going to make your life way more easier. So good light, light the object well, because if you don't, you will going to pull your head forward. And color of the light is important also. About the upper extremity, if we think about the factors what makes the risk of work-related issues concerning about the upper extremity way more worse, is the static muscle work, so longer periods in same posture, shaking of the object, but not in your case, because if the shaking of the object is the issue, then the shaking of the object needs to be way more bigger. So your tools are not doing that. Tools what they use, for example, in construction yards, those are the shakes what cause the issues. And abnormal wrist positions. So from these you got two: static work and in some cases abnormal wrist positions. How to prevent those? To have those pauses, think about the tool handles and think about the stretching. If you find yourself working in this kind of postures with your wrist for longer periods, is the handle bad or can you do it in more neutral way? Because more neutral the wrist is, less issues you will going to have. Issue is that when the medial nerve comes from here underneath the transversus ligaments, then when the compression starts to build in, then you start to having these tingling or numbness in the upper limb area. If you need to stretch these structures, then place your fingers going downwards, then extend your elbow, and this is really easy way to get these areas stretched. If you need to be having stretches to this upper part, and if the movement is good at the wrist, try to do stretching like this, boom, pull your wrist against you, and if you feel more pain at the wrist, then the issue is that the joints are flexible. If you want to increase the stretch in there, put your fingers like this, grab a fist, and then start doing this kind of movement, so the tension comes way more faster to here, because these muscles are stretched out from this posture. And also, if you start to have these tennis elbow issues, then there is a video for that, how to do the maintenance in here, because typically in tennis elbows cases, there is this ischemic pain mechanism on the background, what we need to just sort out. When we bend our fingers, that is normal range of movement to finger, but when we start extending our joints, then you will going to have finger in that kind of placement that if you are pinching the stuff like that, you might have issues in that joint in the long run, because the finger joint are not to be used in extension. They are meant to be used in flexion. So if there is a wide range of motion also in the finger joints, always focus on the flexion grip, because if you go for the extension, you will going to end up having situation, because if you start to have this osteoarthritis in the joints of the fingers, then you will going to have the resting pain during the nights and issues from that. And if you think about the joint and its angles, elbow close to the body, and in this vertical line, keep it close, because if you go way more further, then you need to use way more force to maintain posture. In abduction movement, try to relay quite close to the body, and with the use of the force, use the 90 degree. If you need to have more force, get it to higher degrees. Wrist angles in this way, ulnar deviation and radial deviation, keep it in the middle, and also in this plane, keep it in the middle. And concerning about the supination and pronation, supination is way more harder for the hand to maintain, so aim for the pronation, because it's way more easier for that. And what should be done in a big picture? Here is an example from the low back pain. So ergonomic interventions at workplace are ineffective, and I'm doing it right away. So enjoy. But when you know the pain mechanism, you know how to treat yourself. When you know the principles how to get those stuff adjusted, then you are able to adjust them. When you know what to notice concern about the work, you will going to get less issue for hand osteoarthritis and stuff like that, and that's the way it goes. But if we think about the low back pain about insole, then there is not that much of the evidence in there either. But when we check for the exercise and education, it has moderate quality. So this is the reason why I'm doing this education for you. And if we check about association between lifetime musculoskeletal pains in big population, being physically active is associated with the lower risk of having musculoskeletal pain. In my case, I prefer to bike everywhere because Oulu is biking city, so bike roads are everywhere. You just need to have bikes during this kind of time of the year. In my case, I prefer to go to gym at the Mondays and Fridays, and I don't lift weights because I hate it. So I have taught myself that I will going to go over the gym and do my fairy tale gym. So I do squats, I do push-ups, I do belly, I do back, I do something pulling, and that's it. And if I have some sort of excuses at the morning, sit and go over there and do your task, and I will going to go over there and do my task. No questions asked after that. So aerobic endurance comes from the biking, and also the gym comes from the Mondays and Fridays. And what is good? Think about the persons what you don't end up having time in your daily activities or weekly activities. I had this excellent friend of mine during the studies, and I told him that, okay, do you want to come and wrestle with me? And he told me, okay, I'll be thinking about starting something martial arts related. I said, okay, excellent, you need to come to our class. And he came. So every Tuesday and every Thursday, I know that he will going to be at the same place, so we can have a chat, we can catch up, because we don't end up having those talks in everyday activities because he has work in different place, he lives at a different place, but I know that Tuesday, Thursday I will going to see Joni. Excellent. And when I can take my pressure away with him, hit him and kick him and wrestle with him, it's excellent and we are having good time. But that is the only way how I can keep that person in my life. And because he's that good of the person, I really want to go for my training because I want to see him. And if I don't see him, I get sad. So I get social, I get mental, I get my physical activities from that. So try to find the ways how to incorporate your stuff what you are liking with the best friends of yours, because that is the glue what will going to keep you in there. So concern about the work. Try to always maintain the erected posture, but you know that you will going to end up in a city situation when you need to be working in different kind of postures. No worries, you will going to get used to it. Use the adjustable chair and always adjust it because no one else is not going to come and adjust it for you. Work close to your body because the levels are quite minimal during that, so it would be quite easy for you. Minimize the excessive wrist movements and try to find ways how to get fingers from extended postures because they are meant to be working in flexion. Alternative work position, sitting, standing and side of the patients, and always try to find ways what kind of job task are you able to do in different kind of posture, because when you find that, it will be way more easier to maintain in the long run. Consider horizontal positioning of the patient, so fix their heads and pull their head and turn it so it will be easier for you because they don't get these musculoskeletal issues. You are the person who has, so try to get it easy. First and foremost, correct the ergonomics problems in operatory, so use the furniture and the adjustments of those. If you have issues, get them sorted when you start to have these first issues. Typically when client comes to my office is the situation when they start to have that amount of the severe of the night pain that it's blocking the night sleep. I would gladly be in assist way more earlier, but that's how it goes. So we need to get the nights better, and once we get the nights better, then we need to focus on the everyday tasks or stuff concerning about the work. Major trigger points should be resolved and specific strength training in your case would be shoulders and the back. So get your upper back working, something what pulls you is excellent for your counter movement. Be patient, most of the commit regimen prevention strategies, and if you have task what requires a lot of static work, then do some sort of stretching or some sort of massaging those so you don't get the situation when you have this ischemic pain. If you want to have some sort of guidance to your clients, here is a video what we made with Anni about bruxism. Here is a message of the masticaru muscles, easy instructions for clients to follow. And sometimes there might be some sort of radiating pain in the in the face area, and it's also covered in there. Final questions. Do you have a way how to test the neurodynamics of the trigeminus nerve? Check, for example, if the client has one-sided issue, is there a way how to promote or try to get it relaxed or test the sides of the trigeminus nerve, how well the neurodynamics work?
It's like doing this and this and this.
Yeah.
Is it?
Mouth nerves, yeah. Nervus facialis makes the impression of the face, so if there is issues, then there is something dropping that is not normally functioning. The trigeminus is associated with the masticaru muscles, so there should be some sort of issues in there. But Kirsi Sipilä is the professor in here. Have you run into her? Excellent, excellent person. I've been asking about the client who has this idiopathic trigeminus nerve irritation. So there is no surgery, there is no trauma on the background. And I've been asking for it for years now. Sadly, she hasn't provided me any of that kind of clients. We have this Facebook group in Finland, Relax Your Masticaru Muscles. That is like a support group in Facebook for the person who have these TMD issues. I went over there and there was this one client what did the Facebook post that she has this ulnar nerve irritation, and also she started to have these jaw area tingling and numbness sensations. And I write it after that post. If you live at Oulu, please send me DM or something because I really want to get in touch with you. And she contacted me and she came to my office and she is that client in there. Issue was that she have had both side ulnar nerve irritation from the summer. There was nothing on the background what started the ulnar nerve irritation, but the difficulties with the ulnar nerve irritation was that when she was sitting and standing up and she was putting pressure at these areas, it was so painful that she weren't able to push themselves up, so only uses of the leg. Tingling and numbness has been present from the summer, and that new symptom, tingling and numbness in the left side, started to appear to trigeminus and the jaw area. And when I have a client what has both side nerve root entrapment or symptoms, then I typically don't test the nerve that specifically or test the structures in the nerve pathway. I typically focus on the spine area. So we tested the spurling, nothing was present, and I checked her chest spine. So rotational movement was excellent, but extension was really limited. So we tested first the ulnar nerve, really bad tightness and typical symptoms present, and then I did the mobilization of the chest, and the ulnar nerve started to move way more better, and after that she went to the desk, seat and pushed herself up. So less pain present. So something was contributing to her symptoms. So once we mobilized the chest, the neck was better and the ulnar nerve was better. But the trigeminus nerve remained the same. And if we think about the trigeminus nerve, that is a brain nerve, yes, but that is peripheral nerve also. So with different kind of positioning, we can start irritate the nerve, and if there is a clear restriction compared to the side, we just need to find out how we can get the restrictions away. And when we know that slump posture really pulls the nerves in lumbar, chest and cervical spine, then we just need to apply some more nerve tension. And in this case, I made the neck retraction. Then we made lateral flexion of the head. So in slumped posture, this, and this. And then I asked the client to open up the mouth in this position and move the jaw to right. And that was the non-symptomatic side. When we made the same test with knees bended to left side, there was no symptoms present. But when she did do the extension of the legs and same movement, then she told me that okay, there is a clear symptoms what are familiar to her symptoms. And we tested same way the opposite side and there was no irritation present. So I checked the masseter deep of that, and I also checked the upper neck, and there was on the symptomatic side really easy palpating sensitive structures. I massaged them open, we did the test again, and the irritation was less. So something in the upper neck area and something in the deep masseter was affected on her symptoms. So the takeaway from her was that okay, do these areas massage over there, and if the symptoms start to disappear, then we are going good. I contacted her within after 2 weeks from the visit, and she told me that okay, this is disappeared. I still have some sort of issues in here, but they are way more worse. But the issue was that okay, it dropped severely down, but there was something present still. So she's coming to me within 2 or 3 weeks. But try that, because if you know that you can irritate the nerve or is there clear restrictions, then try something, because if it takes the issue away, then you know what to guide to the clients. Also, other peripheral nerve what might be contributing to the head area is the occipitalis. And how to test the occipitalis? That is the big nerve in the back of the skull, so it's easy. Retraction of the neck. Wait a bit. Retraction of the neck and lateral flexion if I'm testing this side. But try those, and if you start to having typical symptoms present in the test of the trigeminus nerve, let me know also. Because NOI group is a specialized group concerned about the neurodynamics, and I found that from the NOI group's material. And now next time when I see Sipilä, I need to tell her that if you have these clients with the idiopathic background, I want to test them, I want to treat them. Because if you have a trigeminus nerve irritation, only way to treat it is to have shitloads of medicine. And when they get bad, they really get bad, and amount of that pain has in everyday activities, it's bad. So those persons are really suffering. So if we can find some sort of way how to treat those, it would be very good. There you go, there is the articles. But I will going to send these all to Sauna UI, and he will going to send the presentations to you.